this and I'm going to minimize this over here. All right, so this is our topic for this evening, spina bifida. So obviously by this picture here, you can see this, this is a vertebral defect impacting spinal cord and nerves and cerebrospinal fluid. So spina bifida is actually one of the most common birth defects that are considered disabling. And the annual incidence is 1 in 1,000. It is slightly more prevalent in females. And there is a highest incidence in the Hispanic population. So spina bifida is a neural tube defect. So what does this mean? This occurs when the spine and spinal cord don't develop correctly. The neural tube is the structure in a developing embryo that eventually becomes the baby's brain, spinal cord, and meninges. And typically the neural tube forms early in pregnancy and actually closes by the 28th day after conception. So obviously, before many women even realize that they are pregnant. In babies with spina bifida, a portion of the neural tube doesn't close or develop properly, causing problems in the spinal cord and in the bones of the spine. So related neural tube defects do include anencephaly, which is an absence of the brain, and encephalocele, which is a malformation of the brain and the skull. And folic acid supplementation during pregnancy has significantly reduced the incidence of spina bifida over the past 30 years. And interestingly, I worked with the director of the Craniofacial Center at the University of Florida years ago, and they determined the same thing with regards to cleft lip and palate. So similar with regards to the neural tube, that folic acid is tends to be the cause of cleft lip and palate as well. So there are also genetic and environmental risk factors. So there's 3 different kinds of spina bifida. There's occulta, cystica with meningocele or meningocele, and then spina bifida cystica with myelomeningocele. So we're going to kind of talk about each one of those. As far as diagnosis is concerned, screening tests during pregnancy often pick this up. Routine ultrasound obviously is going to pick up a spinal defect. Maternal blood tests, amniocentesis, so a higher level of alpha fetoprotein can be an indication of spina bifida. And if somehow it is not picked up prenatally, then when the baby is born, it's obvious, at least with the latter 2. So again, there's those 3 types, the occulta, the meningocele, and the myelomeningocele or meningomyelocele. So the spina bifida occulta is mild and often asymptomatic. The outer parts of the spinal vertebrae are not completely closed, but it may be very, very minute where the area is of involvement. There's no herniation of the meninges or the spinal cord or the spinal nerves. The skin over that area might be dimpled, might be discolored, might have a hairy patch, or have no sign at all. And I can tell you, I've been around a long time, and I was in PT school in the 70s. We had one of my fellow classmates had been told that he had a mild case of polio, and that's why he thought he had a slight gait abnormality. And it wasn't until he got to PT school and learned about spina bifida occulta and had it checked out that that was actually what he had. So he wasn't, like 29 years old when he learned that. And so that is, many people apparently are unaware of it. And interestingly, incidence is 5 to 20% of the general population, which I thought was pretty astounding. And the potential correlation between non-specific back pain and its presence in children or adults. So again, folks who don't know that they have it, this could be an underlying cause of back pain. Spina bifida cystica with meningocele or meningocele is the least common of all of these. This is where there's meninges protruding through an opening in the vertebra, but there's no spinal cord involvement. And so impairments are rare. If they do have impairments, they may have hydrocephaly, lower extremity weakness, bowel or bladder dysfunction, or an increased risk of tethered cord. And we'll talk about tethered cord here too. And then we get into the spina bifida cystica with myelomeningocele. So this is where the spinal cord is protruding through the vertebra and the skin. The mass of nervous tissue has no overlying protection. The protruding part of the spinal cord is typically damaged or incorrectly developed. And so the surgical procedure performed is basically putting everything back into, to be protected by the spinal, by the vertebra, but it's not obviously changing the nature of the spinal cord injury itself. So that's what a baby may appear like. And then that's after repair. So I used to work in a middle school with kids with physical impairments, and we had a number of kids with spina bifida, the myelomeningocele. And interestingly, not one of them realized that they had ever had surgery. So we actually took pictures of their backs so and taught them what they had undergone. So there's going to be some significant health implications with regards to this disorder. Spinal cord impairment is at the level of the lesion. So you're going to have paralysis, either partial or complete. You're going to have sensory issues, loss of muscle tone, and then impaired bowel and bladder control. Common complications are going to include spinal deformity, and this may include scoliosis, kyphosis, or lordosis, lower extremity orthopedic deformities, including the hips, knees, the ankles, and the feet, hydrocephalus necessitating a VP shunt, and Arnold-Chiari type 2 malformation. So signs of hydrocephalus or signs of shunt failure are going to, and this would be pertinent for anybody working with a patient with myelomeningocele. It's going to be headache, irritability, vomiting, diplopia, dysphagia, seizures, lethargy, or a rapid increase in head circumference. All right, so most of you probably, are aware of what a VP shunt is, but for anybody who's not, I put in this picture here so that you'd realize that the shunt is going from the ventricles, basically just under the skin of the neck and the chest, and then entering the abdomen, and they coil the tubing so that there's room for growth. So that Arnold-Chiari type 2 malformation is a pretty big deal. So basically, there's a subluxation of the cerebellar vermis and the brainstem into the foramen magnum. And it is present in the majority of individuals that have myelomeningocele. It's symptomatic in about 1/3 of the individuals. The symptoms will progress over time. And serious sign is when the brain tissue descends below the level of the 4th cervical vertebra. So just imagine that, how much subluxation that has been. So if you have a patient with Arnold-Chiari type 2 malformation, they're going to have difficulties with feeding, might demonstrate a weak voice or cry, stiffness or spasticity in upper extremities, balance impairments, respiratory difficulties, such as inspiratory stridor or insufficient breathing. Sorry, Mary Helene, one of our faculty, is trying to get on, trying to log on, says the host to join and wave, let them know you're here. Yes. We'll see if she can get on that way. All right, so complications are the leading cause of mortality in these patients. An MRI obviously is going to assess whether somebody has the Arnold-Chiari type 2. Shunt revision might be needed to ensure appropriate intracranial pressure. They may need to do a posterior fossa decompression, which is going to create adequate space for the cerebellum. They might do a spinal laminectomy to increase the size of the spinal canal, or they may actually cut into the dura mater to create more space for the flow of cerebrospinal fluid. So the second most common cause of decline in function in our patients with spina bifida is tethered cord syndrome. And this is where the spinal cord becomes attached to the spinal column. The spinal column stretches as a child grows. So obviously, as a child's growing, if that spinal cord's become tethered to the vertebra, then we're going to start to see neurological signs. So these may include lower extremity weakness, gait imbalance impairments, worsening, because obviously they have gait imbalance impairments, changes in bladder function, and rapidly progressing scoliosis. And so there is a surgical procedure to detach the spinal cord. As far as kidney and bladder function, advances have decreased mortality and morbidity due to renal failure in this population. Obviously, once the baby's born and they realize the issues, they do a complete assessment after birth. Early catheterization and medication ensures full bladder emptying to prevent UTI. So that's a really big deal. And then we do also have to realize that because of the use of the intermittent catheterization for this population, and the chronic use of catheters, that they are at high risk for latex allergies due to exposure over time. The most common orthopedic abnormalities are foot deformities, foot and ankle deformities. Progressive scoliosis is common, and so you might see external support being a TLSO and an orthotic, and or surgery for internal stabilization. And cognitive impairments are related to hydrocephaly and VP shunt complications. And for those who have those issues, the mean IQ is 70 to 90. If they don't have hydrocephaly, or if they remain stable with no issues, the average is about 100. And so the issues that you may see are going to be short-term memory, attentional deficits, and difficulty with organizational skills. And they may have impairments in social skill development, including social language and peer interactions. So, while the physical limitations are going to be addressed more by the PTs and OTs, the OTs and the SLPs are going to be addressing the cognitive and social skill development and language development. So there are a number of tests and measures that can be used for this patient population. There is a Spina Bifida neurological scale, and it's a simple objective scoring system for quantitative analysis of spinal neurological deficits. And scoring is based on motor function, reflexes, and bowel and bladder function. The Spina Bifida health-related quality of life instrument can be used to help define outcomes and the impact of impairment on function. The PD, the Pediatric Evaluation of Disability Inventory, can be used for goal setting and to demonstrate improvement in function over time in 3 areas: functional skill level, caregiver assistance, and modifications or adaptations used. The WeFIM is an 18-item, 7-level scale that assesses performance in 3 primary domains: self-care, mobility, and cognition. And it has been specifically validated for use with children with spina bifida. And I have a note for the SLPs. Most children with spina bifida cystica with myelomeningocele experience significant difficulties in the construction of meaning and in pragmatic communication, both of which require flexible language processing in real time. Assessment and intervention should specifically attend to the development of meaning, construction, and semantic pragmatic communication. And then obviously for PTs and OTs, the other tests and measures that are commonly used are manual muscle testing, range of motion, and sensory testing. All right, I did try to do a review of literature, and really there's not anything out there. So might be interesting for some of you to consider. As far as hippotherapy related contraindications, so these are coming from the PATH standards. Contraindications would be a worsening of neurological symptoms, because you got to figure out, is this the Arnold-Chiari? Is this the tethered cord? What's happening here? Is there a shunt failure? A rapid progression of scoliosis? Poor skin integrity along the weight-bearing surfaces, so something that's going to need to be monitored on a regular basis. Moderate or severe scoliosis, or an inability to achieve a full upright sitting position. Pain that's related to the activity. Inadequate range of motion to accommodate the equine movement. Helmet that can't be correctly fitted, and you're going to have to be really careful because of the realization of the shunt position. And then poor postural alignment in the spine, pelvis, and or lower extremities that cannot be corrected by direct handling techniques or adapted equipment in TAC. Another contraindication is complete spinal cord impairment above T6, but that is rarely seen in spina bifida. So precautions are going to be just the fact that there is paralysis below the level of the spinal cord injury, and there's decrease in sensation, that there's going to be poor abdominal and respiratory control. So you might want to consider use of an abdominal binder. Poor joint stabilization below the level of the spinal cord injury. The hardware, if they've used hardware for spinal fusion, I'm going to say that's a strong precaution. That used to be a contraindication. A spinal orthosis, you know, are you going to use it while the patient is on the horse? Are you going to remove it? Just again, precautions with regards to the shunt. So consider the position that you're placing the patient in. Hip subluxation. And then any asymmetry in the sitting posture. And just kind of sharing the references that I used. And obviously, like I said, the case studies book was very helpful for this information. Since there's no videos or anything attached to it, if anybody does want a copy of that, I'm happy to share. So just email me at hippopt@aol.com if you'd like a copy of that. So any questions before we move on to our therapists that are going to be presenting their patients? All right, well, Amy, since this was all really your doing, let's let you take over.
All right. Hello, everybody. Thank you so much, Carol. That was a wonderful presentation. I am seeing a client by the name of Charlotte whose birthday is today.
Oh, wow. Happy birthday,
Yeah.
Charlotte.
Is 6. So she's been 5, and I have not been seeing her for very long. She started on June 27th, 2023. So she's been coming for 9 visits. It's been about 12 weeks, but she was out of town too and sick once. And she is a sweet 5-year-old female in a Spanish immersion kindergarten program at an elementary school in Vacaville, California. And she was brought to highest potential therapy for an occupational therapy evaluation by her mother. And per parent report, Charlotte enjoys brushing hair, baby dolls, kitchen play, cutting paper, bubbles, slime, kinetic sand. Her strengths include her ability to communicate with others. She is very, very creative. Her compassionate nature, extremely observant and a curious person. The parents expressed concerns about her strength, balance, motor skills, and gross motor skills. Are you guys hearing an echo?
Mm-hmm. Yes.
Do you know what I could do about that?
You aren't double on here. I'm
No,
not seeing you anywhere else, so I don't know.
I think it's because Krista Strafford has her mute off.
Okay, because I don't hear anything right now. Thank you. Okay, so she has myelomeningocele spina bifida Chiari 2 and neurological club foot. She is taking ditropan, nitrofurantoin, and Miralax to help with bowel. She was born via C-section at 36.5 weeks. She spent 3 hours in the NICU. She has a fraternal twin. Oh, and in case you're curious, I did ask the mother if she took folic acid when she was pregnant, because I was just curious, since, we are always taught that it can be prevented with taking folic acid prenatally. And the mom said that actually she did. She was taking a prenatal vitamin actually 3 years before she conceived, and the whole time she was pregnant. So she's not sure why that didn't prevent spina bifida in Charlotte. Her one hypothesis is that maybe because she had twins, there just wasn't enough for both. And they weren't able to perform the surgery. I don't know if you guys know, but there is a surgery that they can do in utero now, but they weren't able to do the surgery because her twin didn't have spina bifida. So they would be putting her twin at risk. So that was interesting. So she has a fraternal twin. She was diagnosed with spina bifida myelomeningocele at 20 weeks via ultrasound. She underwent surgery for the meningocele repair the day of her birth. The day after her birth. At 4 months of age, Charlotte had surgery of her 4th ventricle to create an opening for her spinal fluid to drain. She does not have a shunt. Charlotte has been through 2 tendon release surgeries of her feet and has had her tonsils and adenoids removed. She's susceptible to ear infections. She's had 3 this year. Her last physical, including a vision and hearing screening in May of 2022, was good. Okay, she rolled at 4 to 6 months, somewhere between there. She sat between 9 and 10 months, crawled between 9 and 10 months, and walked with assistance between 18 and 24 months. She's allergic to latex as a precautionary. I don't know if you guys are aware, but a lot of individuals with spina bifida are allergic to latex. And that's probably all that's pertinent to you guys. Okay, so other services.
Amy, can I interrupt you for 1 second? Because we've had a question and I think it should be addressed now before you move on. The question was, I was under the impression that Chiari malformation was a contraindication. Is that correct? And actually, it is the neurological signs of showing a neurological progression that is the precaution or contraindication, not the diagnosis itself. So
Great.
just wanted to clear that up.
Thank you for clarifying that. Charlotte received medically based occupational therapy and physical therapy beginning at 6 months until she began TK last year. She received school-based occupational therapy and transitional kindergarten for 20 minutes one time weekly on a consultation basis. Charlotte also attends occupational therapy one time monthly through California Children's Services. And she is beginning the Spanish immersion kindergarten program. Her dad is Hispanic, so it's pretty cool. She's learning Spanish and English. I love it. And she is in a general education class with an aid that has, I think, helps multiple kids, but the aid is just for her mobility. And she also receives nursing assistance at school. So we administered the WeFim on her and the sensory profile too. So those were both mentioned in your slide. I love it. And if you guys are interested, I would like to see if I can share my screen and share some videos and pictures. I wish I had better videos for you all, but there are a few. And like, as you know, we've only seen her 9 visits. Okay, here we go. Are you able to see my screen? No. Okay. Let's see what happens here. I'm going to do a little test.
No, I think a surgically corrected tether cord is okay. Again, we're looking at the symptoms, but if the cord has been untethered and neurologically they are how they normally are, then that should be fine. Okay, we can see your beautiful picture, and I love the fjord that's in your picture.
Yay! That's the horse that Charlotte rides. That is Leica. She's a Norwegian fjord. We have 3 fjords. We love them. And this is her first day. She got to help lead Leica in from a turnout. And I'm gonna go. Sorry, I don't do Zoom very often. Okay, how do I share another picture? I went to share before. Oh, stop share maybe, and then press share again. Photos. Okay. So the first time she was on a horse is super cute. She loves horses, let me tell you. Now, why can't I do videos? How come there's only pictures?
Is your video in an open file on your screen?
Yeah. Like I made an album of videos and photos, and when I go to share, it only shows me the photos, none of the videos.
So I would just open that up and put that down on your desktop and close the rest of your files so that that's the only thing available to you.
I'm using my phone.
Oh.
Let's see. While I do this, Lisa, do you have anything you want to add about Charlotte? Let's see if I can go to videos somehow. I'm sorry, guys. What we can do if this doesn't work is the next therapist can present and I can work on uploading these all to my computer. That's so weird that I can't show videos. That's the best part.
Yeah, and I'm sorry, I can't help you because I don't do anything
Yeah.
on my phone. I'm too embarrassed to tell you how old my phone is, but I don't I
Yeah,
don't use it for anything.
If I can't figure this out very soon, what we can do, like I said, is I'll transfer all these to my computer while the other therapist shares. But here's a photo. I'll add another photo. Here's a photo of her brushing. You can see the smile on her face.
And remind us her level, her spinal cord level.
Oh, I don't know. It's in her lumbar. I should know that. I'm embarrassed that I don't know that,
Okay.
but I don't. I'll ask what vertebra it's at.
So does she have active hip flexion?
She does have very, very little. There's a video of her doing around the world or just moving from sideways to forward sit. And you can see that she has very, very, very little control from her waist down.
Okay. So she's upper lumbar.
Yeah. Does the other therapist want to go while I see if I can just transfer all this to my laptop and do it from my laptop?
Before we do that, does anybody have any questions relative to just these pictures that we're seeing? Like, tell us about do you know anything about the wheelchair that she's using? And is she able to does she manipulate this wheelchair herself independently?
She does. And I have a video of her independently wheeling her wheelchair. And I don't know why I can't share it, but I will.
Okay.
Figure it out.
And does she have okay, in that picture, she had a pelvic belt on? I mean, she
Yes.
didn't look like she needed to have any kind of trunk harness or anything. She's got good enough control from like the hips up that she's able to reach for the horse and regain her.
Yes. On the horse, she presents with a very anterior pelvic tilt and she tends to lean forward. She feels very insecure and she definitely has poor core strength, but she has some, but we are working on it and it has improved greatly. Actually, now she sits so much more upright than she did in the beginning. But in the beginning, she was very nervous and would tend to rely on her upper body and holding on with her hands.
So can anybody here theorize why she has a tendency towards an anterior pelvic tilt when she's on the horse? Thoughts? Okay, so if we think about the nervous system and the neural levels, okay, so that upper lumbar is like L1, L2 is going to be the hip flexors. And so she has some hip flexors, okay? And so do you all remember where your hip flexors, where your iliopsoas originate?
Yes.
You want to share?
Oh, I was gonna say if she if she has a little bit of hip flexion, like she indicated, but she doesn't have the glutes to counteract that, she won't be able to
Exactly.
hold
Yeah.
her pelvis. And also, if she's already started to get tight in her hamstrings because of the chair, her hamstrings are going to counteract that as well.
Exactly.
So you would, in my experience, you would have to either have your sidewalkers position her limbs to counteract that or try stirrups. So she's not fully in an anterior pelvic tilt, stressing the back more.
Great. Yes. Perfect. Thank you. Yeah, that's exactly right. Because no matter how low our kids are with regards to their level of lesion, they don't have hip extensors. You know, that's like S1. So just like, you know, they're lacking bowel and bladder control. It's the same thing here. And so what you basically are dealing with is just a muscular asymmetry. Mary Elaine says, ding, ding, great response, Allison. All right, go ahead, Amy.
Okay, so I have logged onto my iCloud from my computer. So I'm going to join the Zoom on my computer. So I might be double for a second, but then I'll leave from my phone if you want to let me in. And then you should be able to see the videos because they're showing up on my iCloud. Yay!
Good, yeah.
Progress.
Okay, so I left from my phone and camera turned on. Okay, share screen. And we're gonna say share. Okay, so here's my iCloud. And here we go. This is a video of her leading the horse. She's so
Oh, I'm
happy.
so sorry, Sue. I had no idea at all. So thank you very much for being the person admitting, because I know I'm not seeing that. So thank you for letting people in.
Do you all see that picture of her?
She's adorable, and she has a pretty upright trunk there.
She does. She's getting so much better. And she does much better when she is holding an object or her hands are resting on her legs as opposed to hanging on. She has a lot of fear. She loves to trot and she loves to ride the horse, but she has a lot of fear, which I think is probably due to her decreased postural control. And she does lose her midline orientation often, especially when the horse turns. Right now, we're doing a lot of straight lines and a medium walk because she's just not able to tolerate a lot of turns. She'll often go off to the left side. Very weak. So here she is leaning forward. These pictures might be out of order. She's holding on. In the beginning, we let her hold on just because we wanted her to feel secure. Oh, look how happy she is.
Everybody be thinking about why.
Yeah.
What are her issues as to why she struggles with a directional change. We've got that centripetal and centrifugal force going on, and what do
Here she's throwing a beanbag. When we're able to get her to toss something or engage in activity, it really helps her position.
turns? What
You're breaking up a little bit. All I heard was turns. Are you guys still
Amy,
able to hear me?
you were like really like Charlie Brownie.
Oh,
And Carol, you were frozen for a minute there.
Oh,
That
so
was
okay. So
odd.
that was okay. So
Yeah,
that was potentially my internet. So that I
You're
didn't
back
hear you.
now.
Okay.
what was your question? All I heard was turn.
Okay. So my question is what muscle group? What primary muscle group do we use to maintain our balance when we are making a directional change?
Rectus.
So the rectus would be more for an acceleration. So think lower.
Are you talking like medius for lateral trunk, or are you talking like obliques?
So I'm thinking hip adductors.
Oh, well, yeah.
Yeah, because if you don't have anything to stabilize yourself below your hips, your trunk can be working all day long, but centrifugal force is still going to be kind of shooting you off to the side, and you have no adductors to pull you back in. So, that's where the therapist and the sidewalker are going to have to be her adductors. I mean, obviously they're providing her stabilization. So, obviously what Amy's working on is the trunk. And yes, if you're stable from the hips up, then yes, you're going to be using your rectus and your back extensor simultaneously. So it was just, my thought was, she is always going to feel apprehensive to a degree because she doesn't have A, sensation, or B, motor ability, below the hip flexors.
Here is a video of her very first moment on a horse ever. Were you able to see that? Uh-oh.
Yes, I enjoyed her turning and looking at you like just in such enjoyment.
And here's after the horse that day, we always do traditional treatment strategies and tools afterwards. So it was very hot this week. It was June in the Sacramento area of California, very hot. So we had a water theme that week. Sorry, they look kind of blurry. I don't know why they're not blurry to me, but on Zoom, they're showing up blurry. Okay. We can find some more videos. I don't have a ton of videos. But here's one of her changing from sideways to forward sit, and you can see she's using her upper extremity to move her legs as opposed to her lower extremity. Any comments on that? Are you guys with me?
I just liked how she like brushed the horse's mane as she was moving her foot. I think she realized she was kind of pushing on the mane, and she kind of patted the horse's mane.
Yeah. Here's another video. Oh, this is stop starts. So you can see she's really relying on her upper body, her upper extremity.
Can you pause that for a minute, Amy?
Yep.
So does your facility have the rule that you keep your hand on the safety belt at all times?
We don't have a rule per se, but I do that just based on my training at the AHA level 2 course that I took
At Skyline?
at Skyline.
Yeah. Okay, so
Yeah.
that's not an AHA teaching. It's a
Oh, okay.
Skyline teaching. Okay, so just allow me a moment
Yeah.
to just point out, does anybody else want to comment before I do on why she was struggling leaning forward and why she had to be so reliant on her hands?
Can you go back a second, about 10
Yeah,
seconds?
if you can you reverse the video?
And then let me take a look.
Here. Tell me when.
Just keep going.
All the way to the beginning?
Yeah, that's good. Yeah, good. Yeah, let's just go from the beginning. Yeah, and obviously, guys, this is not this was wrong or this is right or whatever. This is all just let's just use our clinical reasoning here to say, okay, if we experience this with our own client, what could we do differently to help the client be successful? So she's so happy right here.
And so her leg seems to be going very far behind her body, which is then tilting her forward even more.
Right. Yeah, that's right, Michelle. Yeah. So Amy, go ahead and do this again. So, again, you have been taught to hold on to this gait belt, but unfortunately what's happening, like Michelle just said, is that leg is just swinging back. And so if you swung your leg back, it would bring you forward. That's just physics. So if you were to support her in a different manner, that would give her proximal, stability at that hip and keep the alignment of the leg and the pelvis, then she wouldn't be going forward.
Okay.
So does anybody want to suggest any different way? And we realize this is a snapshot in time, Amy. So you've very likely done other things with this patient. This was, very early on in the in you seeing.
Yeah, this is helpful. Thank you. I appreciate this. I want help.
Amy, what does she look like? Have you tried stirrups? Curious?
We have not tried stirrups, but now she is so much better. And I don't know, Lisa, if you have anything to add. My level 2 student is here as well, Lisa. Now she's doing so much better. She rides with her hands on her legs. When she's on the horse, she has her hands on her legs, and she is sitting so much more upright.
Yeah, and that's why I said all we're doing is we're addressing this moment in time.
Yeah,
this
no, I
little video
appreciate
that
it.
we're seeing, just to get the wheels turning here. So oftentimes you'll see people do the forearm across the thigh,
Arm over thigh.
stabilization, and that would potentially work.
Okay.
Probably, my favorite way is literally cross it over, and I would take, if I was on her right side, take my right hand, which is the farthest away from her, and put it on her thigh, and then take my left hand and have it behind her heel. That way I'm guaranteeing that I'm going to maintain a perpendicular to the ground position of that lower leg, so that it's not going to swing back, and then she's not going to fall forward.
Great idea. Thank you. Here's a photo of her reaching out of her base of support to engage in a really fun activity that our level 2 fieldwork occupational therapy student Lisa here in the photo came up with and made. We were learning about tomatoes because the kids planted tomato plants several months prior, and this week they got to harvest tomatoes and make a salsa, homemade salsa, after they were on their horse. And so during the horse, Lisa made this really cute magnetic game where they would go find the different parts to Mrs. Tomato Head, kind of like Mr. Potato Head, around the arena. So there was a stem, 2 eyes, a nose, and a mouth. And then they would bring it to the board, and it had a magnet, and they would reach out of their base of support to place the features where they wanted them. And then they could follow the instructions. So if they had just placed the stem, then next time they walked on, they would place their hands on top of their head. If they did an eye, then they would get to trot. If they did the nose, they would get to do the walk halts that you saw in the video. And then if they placed the mouth, they would get to learn or share a tomato fact. So just incorporating some academics in there. So here you can see she is sitting up a little bit better. I think she has her right hand placed on the horse's withers. But this is improvement, because when she first started, she didn't want to take one hand off. She didn't want to reach with one hand at all. So this is great improvement.
Amy, do you want to share how you made that device that you have Mrs. Tomato Head sitting on, like that whole look? I see a PVC and I see some metal. I'm just wondering exactly if you just want to share how you did that.
Yeah, Lisa, feel free to jump in and share if you would like.
Yeah, sure. It's just a magnetic whiteboard that you see, and I really just taped on or like put on a piece of paper, and it's just tied on with some rope. The rope goes all the way around the whole board, and then I use some binder clips, as you can see. So yeah, it's really the T PVC pipes that really helps hold it together.
Just a regular pole that you all have.
Okay, thank you. Very
Yeah,
clever, very, very cute idea.
It was a huge hit, and it was very gradable for many levels and ages. So Lisa had placed the features of Mrs. Tomato Head around the arena on top of upright poles in a little berry basket with a bean bag just to weight it down. And they would get it at the walk or at the halt, depending on their level of ability. It's very cute. And then here she is making her salsa, and here's her twin sister. Or she's eating her salsa that she made.
So they look very alike. Are
Mhm.
they identical?
They're fraternal.
Okay, because I was going to say it'd be very weird to be identical and then one get that
Yeah.
the tube defect, but they do look very similar.
So look here, her pelvic alignment is better,
Mhm.
and
So-
her overall position.
If I can jump in, I just have a question. Have you tried stirrups with her?
We have not tried stirrups, but that is a great suggestion. We can definitely try.
Yeah, I think I found a lot in kiddos, especially kiddos who have that lack of muscle symmetry, and so that iliopsoas is really pulling their pelvis down. If you can, but even so, even with kids who do have glutes that are active, sometimes just the weight of the leg and the hip, if they're sitting all day, their hip flexors are tight. It will pull them into an anterior tilt anyway. So unweighting the legs with stirrups can help with that alignment. And it can also widen the base of support, which you might be able to see her be able to have a little bit more postural control with that
I'm listening.
stop and go, or the half halt kind of situation, because she'll have a little bit wider base of support to help her maintain her balance. Just a thought.
Thank you. We'll definitely give that a try for sure. Here is a video of her wheeling her wheelchair down the barn aisle.
What's in her hand? Is there something in her hand
Let me look. I forget.
on the right?
Sunglasses. She's very sensitive to the
Oh,
sun.
okay. All right.
Very sensitive to the sun, so she's carrying her sunglasses.
Okay.
Yeah.
She looks kind of generally low tone, is she?
A little, yeah, definitely. Yeah. Oops. Oh no. Just my iCloud again. Oh. Keep talking without me while I figure this out again. Sorry.
So I have a question.
Yes.
Just in general, I mean, not necessarily about her, but I've worked with some kids with spina bifida. I haven't used the horse at all, but I always think that I'm going to help correct some of that lordosis with a lot of abdominal exercises, and it never works. Has anybody else had any success with that? I don't know if I'm missing something, or I know it seems like it should work to help kind of correct some of that extreme lumbar lordosis that these kids get into, and I just haven't had luck.
I think it's kind of, it's just dealing with that same issue that Mary Helene was just talking about with the stirrups, is that the hip flexors don't have their antagonist. And so if you think about when you perform a pelvic tilt, what are you activating? It's not just your rectus. It's not just your abdominal trunk flexors. It's your glutes as well. And so if you just are activating the rectus, but nothing on the other side, I don't know that you can change things. You're still dealing with such tight and active hip flexors, and the fact that they sit in a wheelchair all day long. So their hip flexors are really, limited in range of motion oftentimes. So the problem is that the iliopsoas, they originate on like your lower thoracic vertebra. And so they are pulling that the spine forward and kind of causing that lumbar lordosis. So, you know, it's really hard to counteract that. And like you said, you know, you certainly can engage the core and get it more active, but because we're lacking those hip extensors, it's
Yeah. The little girl I'm thinking of, she can do bridges. Not she doesn't sustain it for long, but she can do them briefly. But she'll do, if she's in a good mood, she'll do like 50 of them. But but she still has a really strong, really severe lordosis. She's 12, I guess now.
So Lisa, I wonder, do you ever palpate? Does she have real good glute engagement when you do that?
No, not great.
Because you can bridge without using your glutes.
So like hamstrings.
You can use hamstrings. You've got pressure on your feet on the ground. You can use your hamstrings. You can use your back extensors that you have. There's a lot of really great substitutions.
Yeah, that she might be doing that. I'll have to look at that
Yeah,
more.
you got to get your hands right on those glutes. See what you feel.
Yeah.
I just wanted to point out this picture. Her alignment looks very good.
Lovely, actually. I was looking at that.
Yes, it does.
Yeah,
Yep.
it's lovely.
And this was August 9th. So this was more recent than those other photos that you saw.
Okay.
But the smile hasn't changed. The smile's
No.
just as big.
So Amy,
Yeah.
where are you on the fronts of her legs? You could see where Lisa was, and she was on her pelvis, but where were you? Were you
I was
providing her any support or stability from in front?
I had my hands, well, it looks like in this exact photo, I probably just had one hand under her knees, beneath her knees.
Okay.
Mm-hmm. She also loves the swing. We do a lot of work on the platform swing here. She's using a bow and arrow that Lisa made, that she built out of PVC and wood and other materials, and hitting a really neat target that Lisa made as well. I don't think I have a photo of just the target. So she's in Taylor sit on the platform swing, working on her core control. Oh no, not again. Oh, here we go. Okay.
Lisa, were you having her use that bow and arrow while she was moving on the swing or while she was stable on the swing?
It was pretty stable. If it did swing naturally, we kind of let it, but we weren't trying to force any major movements so that she could focus on the task.
Ooh, okay, you guys. Well, first I'll show this video. Okay, I took this video, so I'm very close up on her pelvis. See how she has her hands on her legs now?
Yes.
Still anterior tilt though.
Yes.
Getting there.
Yeah. Well, you know, there's going to be a finite end, you know, I mean, obviously we realize the limitations, but it's so exciting to see how far she has come in just a couple of months.
Yeah, 9 visits over 12 weeks.
Oh, you guys do a little bit.
Yeah.
I was just gonna say, I need Lisa to come work with me.
Mm-hmm. She's amazing.
So many fun ideas.
Mm-hmm. And she does not have a shunt, by the way. No shunt.
So according to the information that I shared that I had researched, then her IQ should be higher than somebody with a
Yes.
shunt.
Her IQ is very high. She's in a general education class. Her communication, her speech, her cognition, her memory with us is excellent.
that reminds me, I think, oh, this is cute. You can really see her language here. She's asking what the theme is for this day. Cute. She was so excited to find out what we were doing that day. Here is wait a minute, what happened there? Is that it? No, it's 41 seconds. Hang on.
Where do you get your safety belts?
Custom made from the same guy in New Mexico that Skyline uses.
Okay.
He's very old school. You mail him a paper form with what you want and a check.
Oh, okay.
But they're great. I love them. And we do not have any hard and fast rules about holding onto the belt. In fact, a lot of times I'll rest my shoulder and switch my hold. But with her, she's very unstable on the horse. And so I tend to have a pretty good grip on her just in case. Oh, this would be good to see her high kneel. We've been doing some high kneel, which is tough for her. So here she's in our sensory motor room, stacking blocks really high and high kneel. But we had to encourage her to do high kneel a lot. She wanted to stay in low kneel.
Yeah, so high kneel is definitely going to be hard for somebody that's lacking glutes again. And again, realizing you are OT and I'm PT. So, this is where it's really lovely to just be able to, because I'm seeing all kinds of really cool things and I'm learning all this great OT stuff and I'm loving it. But if you don't mind going back for just a moment to that high kneel position.
Let's do this.
Yeah. So she's in, what is she? Is she in AFOs, SMOs? What is she? I'd imagine they're AFOs.
Yeah, they're AFOs.
Yeah. So the problem with an AFO and tall kneeling is just that you're in 90 degrees ankle dorsiflexion. And so that foot is like, literally those toes are getting jammed into the floor. So if you think about tall kneeling, with the idea being that you tend to plant or flex your foot, it would just, obviously she doesn't feel it, but, she would be a little more stable and it would probably sensorially be better for, or skin integrity wise, be better for her if she wasn't in her AFOs while she was doing the tall kneeling. So, and other people, please chime in if you disagree with me or, if you have other thoughts with regards to that. But the other thing I'm just going to say too about the tall kneeling is you can see how much anterior pelvic tilt she's in and how much lumbar lordosis she's in. And so, the problem is that you've bilaterally are bringing her into high kneel. So do you do any hip flexor stretching? Do you do any unilateral hip flexor stretching? Like, again, you guys are not, your OTs, you're not PTs.
Yeah, we have not been doing any passive range of motion stretching, no.
Okay, so thinking about the kind of stretch where you lay them on their back on a mat with one leg, well, just very close to the edge, flex up both knees, then have them hold the knee that's farther away from the edge of the mat and let the other leg come down so that you can get a stretch of the hip flexors on one side at a time. But it's just like stretching hamstrings. We don't do those bilaterally, and stretching hip flexors bilaterally because they're both attached to the pelvis. And so when you're trying to stretch out both of them, they're just pulling. So again, remember that the hip flexors are attached to the lower thoracic vertebra on the, the fronts of the bodies of the vertebrae. So they're going to pull the spine forward. So, just, you might want to try offering a little bit of glute, you're not activating the glutes, you're being the glutes. But if you brought your hand into her bottom, into her glute area, and a hand on the abdominals, you might be able to passively be able to get her into a little bit more of a neutral alignment.
Thank you.
And-
Thank you. We'll give that a try.
One thing I do to compensate for if I'm keeping a kid's AFOs on, I'll fold a mat and have them on a mat with their toes coming off the end so that
You don't
or
have
on
to take them
whatever
off.
it is, like a mat table, but this way their foot is hanging off the end a little
Mhm.
so that it compensates for the fact that the ankle can't go into dorsiflexion or plantar flexion at all.
Good idea. Thank you. Love all these ideas. Keep them coming.
I love this horse. Who drew the horse?
Lisa.
I was going to say, let me guess.
Lisa drew the fjord. This is Frodo, one of our other fjords, and had the kids doing a group effort art project for Art Week last week. And so they would spin around. I don't know, you probably can't see, but on the other side of the gymnastics mat. So say she spun around 180 degrees, the tissue paper is there, and she would cut the tissue paper with scissors. So again, we're OT doing fine motor as well. And then spin around using her hands, her upper extremity, to maneuver the swing 180 degrees back to the poster board. And then she would glue on the tissue paper. So we're getting vestibular input, working the upper body. And you can see she's very front heavy on the swing. The swing itself is level, but she is just very top heavy on the swing and causing her to be quite a little bit more inverted than other kids.
Well, and again, you can see her hip flexor tightness. If you look at where her shirt ends, you can see daylight through that area. So you know that her hips are flexed. Yeah. You see that daylight through there?
Yep.
Yeah.
Definitely. And then this was another painting activity. Sorry, took so many pictures. Just trying to make sure we had good pictures for today.
These
So
are
she's used
beautiful.
a Q-tip. She painted with the sponge paintbrushes on a pie tin, and then used a Q-tip to work on fine motor skills to make a little design. And then she screen printed the paper and pulled it off. And there's the result.
Wow.
That was fun. I feel like I
Really
missed
cool.
one thing I wanted to show you guys. Oh, this is cute. Just so excited. She puts on her helmet independently and gets out her helmet and belt from the drawer all by herself. It was Shark Week that I wanted to show you. Oh. Yeah, so we had a Shark Week over the summer, and this is a game with a die, and you roll the die, and each of the 6 sides has a different game. One is Feed the Shark, which is where you go to the basketball hoop, which we've converted into a shark, and you put balls into the hoop, which you pretend are fish. Another game is Red Shark, Green Shark, so like red light, green light, or you could do stop goes. Another game is a shark song or fact. So for the littles, we sing a song about fish or the ocean or sharks. And then for older kids, they learn a shark fact. And then there's Papa Shark, which is like a ball popper toy. You know, those toys that you squeeze and they shoot the ball out. That one. And then there were 2 other games. Oh, Shark Chase. This one's really fun. If you have extra volunteers, they pretend that they're riding a shark, like their horse is a shark, and the volunteers are running, like walking around the arena, and they have to chase the fish to get the fish, and we pretend they're salmon or something delicious. And they depending on their level of ability, will do turns and maybe speed changes and, you know, other direction changes, maybe trotting if they couldn't tolerate that. And then they tag the fish, the volunteers, and then they pretend to eat them. So that's a really fun game, Shark Chase. And then I can't remember the sixth one. Do you remember, Lisa? I could look in my ebook. I have, if you guys are interested, I did make an ebook about different activities and games that you can do when incorporating hippotherapy as a treatment tool. And I have a bunch of printable games that you can print and make and use if anyone's interested. And the Shark Week is in the book. Oh, I keep doing that. So I think you can see our shark basketball hoop here somewhere. Oh yeah, here it is. I think we looked at this picture earlier. She's really leaning back. So I know you guys have seen her in a lot of anterior tilt, but she also goes the other way too, because she doesn't have that control. So here she's feeding our shark. I don't have I should pull up another picture of the shark. The whole backboard of the basketball hoop looks like a shark mouth. It's really cute. Can find it.
So is this like summer camp, or is it you guys do these activities year round?
We do this every week. We have a different theme just to change it up and make it really fun. And we grade all the activities for individuals' goals. You know, no child is cookie cutter, no session is the same, but we just try to have themes because studies show that children learn best in themes and with repetition. So we love to do that, and we just love having it be different and interesting every week. So we try to have a wide variety of activities that have to do with the theme, that incorporates sensory, fine motor, you know, core strengths, etc. And then we just change and modify and adapt to meet the needs and goals of each client.
You're getting a lot of interest in the chat, Amy.
Oh,
So
I'm not even looking at the chat.
If you want to be, in the chat, put information about how to access you for your ebook, because there's a lot of people expressing an interest.
Will do. This was not just, you know, I'm not trying to advertise or anything, but this was about learning more about Spina Bifida. But yeah, since you guys were commenting about all the activities, I thought, well, if you're interested, I can let you know. It's on Etsy, and it's a printable packet. It's a PDF. It's a giant 326-page PDF, and actually several PDFs. And we have a theme for every week of the year.
Okay, so are they looking for your name, or what is your Etsy shop name, or what are they looking for?
The ebook is called The Therapist Saddlebag. Let's see, let me go to Etsy. Oh, I can't spell. Oh my goodness, watch me not even be able to find my own thing here. It looks like this. Oh, there's the shark basketball hoop. Look at that. So we have some examples of activities here. This is for Memorial Day. Take a boat to the water. There's Frodo. That's the horse that Lisa drew on the poster. But anyways, I don't want to take away too much time. I think that's pretty much it. I think you guys have seen most of the pictures and videos. This was a really cute game that Lisa came up with. We did a camping week, and she had the kids pretend to build a tent on their horse, and we used a bed sheet and poles. And you can see Charlotte, she has both hands off the horse, and she's lifting them up to lift the sheet up and over the poles. And then after their horse, some of the kids set up a real tent, and then some of the kids just did an activity inside of the tent that we set up. That was fun. Some of our clients even built a real campfire and got to make s'mores.
Oh my goodness, wow.
Yeah. Yeah.
Okay, this has been awesome, Amy and Lisa. Thank you guys so much for sharing all these fabulous ideas. Like, what fun, to every week there's a different theme. That's fantastic.
Thank you. We love it. And this isn't even very many of them because she hasn't been coming that long. I did have a couple of questions, if you don't mind. I'm going to stop my screen share. Oh, sorry, the lighting on my face is terrible. So you all mentioned stirrups, which I think is a great idea. The reason why I haven't tried stirrups with her is because I don't like the stirrups that go on the Supercore bareback pad, because they tend to put the leg in too forward of a position. So if we use stirrups for us, that would probably mean putting her in a English saddle, which is fine, but then it wouldn't be as easy for us to utilize side sit and backwards positions. Do you all have any thoughts or tips or recommendations regarding that? Have
If
you all
nobody
used?
else is. Yeah, I've just tended, again, Amy, you have grown accustomed because of who you took your part 2 with, to use your hand on the safety belt. But, you can position the leg and you can bring it back. And if you had your hand, the hand that's closest to the horse on her heel, and you had a hand on the anterior thigh, you could open up her hip angle a little bit and counter it with the other hand, and you could get that leg into a better position. You'd be kind of, just repositioning where the stirrup ends up going. I get what you're saying, because all of these pads tend to be a little forward of where a saddle would be. And yet, if anybody could probably benefit from a slight bit of an anterior position of a stirrup, it would potentially be somebody like her, because you want to bring that pelvis back a little bit. So it probably wouldn't hurt her as much as it would somebody else. And the idea too is you're just off weighting those legs. She has no muscular activation in those legs. So you're just helping to off weight them a little bit, give her a little bit more stability.
Carol, I was going to say the exact same thing.
same.
Yeah, I don't worry about that in a kiddo with a spina bifida. I don't really worry about their leg being too far forward, their foot being too far forward, because they're not going to really be utilizing those muscles in the same way. And I'm just looking for alignment, because I'm trying to activate what they have. So if I can make the pelvis to be in a better alignment and their foot is a little bit more in front of where we would want it on a typical person sitting in sitting on a saddle, then I don't worry too much about it. But I also agree with Carol that I don't get too hung up on the belt. My hands is close by that belt. I don't touch a belt unless I have to. I have it close by and I can get to it if I need to, but I find that having a hand on the belt can almost be a hindrance. It prevents me from doing that kind of other type of supportive and facilitative work with my hands, because these are our tools. And one of the reasons why we prescribe or recommend a belt with really big loops is so you can grab it when you need it. So you don't necessarily have to have those hands on the belt. You have to have them close by so you can get to those loops, and those loops are nice and big, so they're easy to grab. But I find that it's not often that I have my hands all over the belt, because I need them other places.
Yeah, thank you. I'll definitely experiment with that. I like your ideas for this particular patient. What are some other holds you guys typically do for a patient who doesn't need support? Do you do an ankle hold or a calf hold?
I'm
I
usually at
could,
the heel. I'm usually at the heel.
Yeah.
I don't like coming in anterior on the ankle, because the problem is that you tend to then swing the lower leg back, and then that brings them forward. So coming in on the heel and giving a little bit of distraction down is usually what I'll do.
yeah, and that
Yeah,
helps you
Allison
be
is
able
good.
to keep the heel from like bending too far back or gripping. You get an idea of how much they're trying to grip the horse. If you have a hand kind of behind their ankle and around their heel, you have an idea. I will also very often, and I'm really try to, as much as possible, especially if they don't need a lot of assistance, I want to make sure if I have someone on the offside, because I might be doing some alternative positions or developmental positions, I want my offside walker to have the same kind of a symmetrical hand placement as I have. And I very often will just have a hand, if they don't need my absolute support to sit, I may have my hand behind them, resting very lightly on the pad, so I can grab that handle if I need it, but I'm not actually touching them. And I may have a second hand, like Carol said, nearby there on their ankle, or I might have it on the front of the pad, so it's near their leg if I need to have a hand on them quickly. But that I'm close to the belt, but I'm not on the belt that often. And maybe I may just have a hand on their, on their thigh. Close to the belt, but not always on it. Allison, you had?
Yeah, I didn't see the pad you were using to play around with the stirrup position. You guys are doing a great job. Thanks for presenting also. But you're right about it bringing them too far forward. I've always been, and so that bothers me too. So sometimes I have to give up one thing to get another thing. To your point, on some of the equipment, you can take the stirrups back and attach them to pull them back just a hair, and you'll get a few degrees of flexion in the lumbar spine that way, as long as they're not dangling. Another thing I did, I think I had Velcro pads or something at one time. I think I made something to go under the thigh to kind of support the thigh so it wouldn't fall. Because my concern is if I drop the thigh, it's going to kind of sling them forward into anterior or lose their balance. But you know your kid, you have to know how your patient feels in your hands, and you kind of know what they do. But the other thing is I'm always concerned about using the legs to go to find out where exactly the position is where I first start to get lumbar extension, because I don't want to be anywhere near in a closed lumbar position, because I'm concerned about compression, especially if they can't report to me what it feels like. And oftentimes kiddos won't tell me if I'm in too much extreme extension, especially if they're that way in their chair or something. So I kind of move their body and I find neutral spine, and wherever that leg rests to give me neutral spine, that's where I hang out, because I'm nervous. I'm a little nervous about staying in too much extension. Does that make sense? But you're right. You give up one to go to the other one, and you think, well, can I do? And sometimes I'll change the position, so I'm covering about 30 to 50 degrees leg position. So that's one way I do it, but there's not always rings or clips to where you can tie those stirrups back. But if your saddle or your equipment allows for that, I'll play around with that position too.
Excuse me, can I just ask Sue, since you seem to be the admitting people, Carol got bumped off. Can you let her in again?
Oh,
She just sent me a text. Sorry
Yes,
to
I can
interrupt,
try.
Allison.
I'm looking to
I
see
wonder
if
where
she's
she went.
in the room. I didn't see the button. I'm sorry.
That's okay. So if you go to, I might be able to help you. If you go to participants.
Uh-huh. Oh, there it
And
is. Yep.
okay,
Carol. Yeah,
there
it
you
had
go.
admit there. Yeah, just not on the regular page. Got it.
Okay.
She's in now.
Okay.
I
All
don't know
right. Yeah.
why I
You
got
must have been
assigned
the,
to
you know
submitting
what? You
people.
must have been the first one to log in, so it made you the host.
Oh.
You could go to Carol's name, and then on the right-hand side where the 3 dots are, you could make her co-host.
Oh
think
yeah,
that's
look
an
at that.
option.
I am the host.
Yeah, you're the host, the hostess
Oh,
with the
that is
mostest.
so funny. Okay, make host. All right, Carol's now the host.
Actually, Sue, stay the host, make me the co-host. My internet is unstable tonight.
Oh,
and
okay.
so that's why
So
I got
you might have
bumped
to
off.
make, since she gave it to you, you might have to give it back to her as co-host.
Oh, all right. Sorry.
That's okay. No. We've learned these tricks of the trade through the webinar.
Mm, yeah.
All right.
Who knew?
I've made you co-host. That way, if I get
All
bumped
right.
off, we won't lose everybody.
Okay, perfect.
Anyways, Allison, I'm sorry we interrupted you. I think
I think I'm always just worried about the, I mean, I've seen some kiddos that, I mean, well, you guys have too, where they look like they're wheelchair. And I mean, I've had them in almost 90 before, and that does kind of bother me. But when I have them on the mat, I'm assessing how much passive mobility I can find in the lumbar spine, and that kind of tells me where to start.
exactly. That's an excellent point. So anybody who's not used to assessing spinal mobility in a patient, that is something that you should get used to doing, because you need to know how much spinal mobility your patients have, so you know whether or not they can actually absorb the movement of the horse. That's one of the reasons why it's so careful to be looking at if there's any spinal hardware, any fixations, and oh dear. And I just got to sign my battery's low, so I got to find my plug.
Okay. Well, Olivia's been waiting in the wings here for quite a while, so we still have another therapist to present. So Olivia, why don't we invite you, if you're still with us, to, there we go.
Hey, everybody. Okay, share screen. Okay, can everybody see this screen?
Yes.
Okay. So I'm a physical therapist. I graduated 2019 and I work in Waukesha, Wisconsin. So this is Madison. She's 14 years old. She began physical therapy with us at Life Striders in September of 2021. Previously, before that, she was seeing a speech therapist at Life Striders, and then she came onto my caseload in 2021. She just began freshman year of high school. She's super excited about it. She participates in extracurriculars such as ballet, Team Impact, where kiddos with special needs are paired with different collegiate sports teams, and she loves it. The whole Marquette team came and watched her ride one day. It was really special. She receives OT and PT in school. She's very fun, very social. I'm very glad about your presentation, Carol, and the information you gave. It was really helpful. Madison fits a lot of the presentation of spina bifida to a T, so we'll get into her medical history here. So she has, I'm so bad at saying this word, myelomeningocele at L4, L5, S1. She does have a shunt placement with her most recent revision in 2021. She has scoliosis with corrective rod placement in 2019. And she has had 5 lengthening procedures, and they don't plan on taking the rods out. She does have the Chiari-2 malformation. And last year, a lot of our therapies got put on hold because she was starting to have those neural flare-ups, not at in our sessions, but afterwards she was getting these really intense migraines, lots of neuro symptoms. So I threw the contraindications in here because it's always nice to just get a refresher on them. The Hippotherapy Association carry two with neurological symptoms, and PATH is emergent contraindication if you see those symptoms develop, and you have to have that medical clearance to resume. So recently, she also had a tethered cord scare that they ruled out via MRI, but she had some bladder changes, and they found out she was having a UTI. So, Carol, you really captured it where there's so many comorbidities that come along with this diagnosis. And over my 2 years of seeing Madison, I'm starting to see more and more things kind of crop up with her. So here she is again. She has that right curve. Because of the rod placement, she does have a pretty pronounced and fixed lumbar lordosis. She has more weight through her left ischial tuberosity, and her left lower extremity appears longer in sitting. She has no sensation from levels L3 to S1. So again, that's a PATH precaution. And as we said, making sure her family's doing those skin checks on her is super important. Because of her, issues with alignment and her scoliosis and rod placement, she has very limited ability to have maximal inspiration and expiration. So normal values are 2 to 5 inches, and she's about 0.39 inches with her maximal inhalation and exhalation. So active range of motion, she does have contractured hip flexors and hamstrings. She's significantly limited hip flexion, hip flexion, knee extension, hip rotation both ways, and then rotation at her trunk. And then passively, she's lacking about 100 degrees of hip extension bilaterally, lacking 110 degrees of knee flexion. And it's pretty even side to side. Manual muscle test wise, she is 0 for all groups below about L3, and then I put some key muscle groups in here. So if we're looking at her rectus, she can lift her head up, but she can't go any further than that. Palpation to those deep abdominals is very trace, if anything. We worked for a long time and trying to get her pelvis a little more neutral with her lumbar spine, but it's so fixed. And as we've talked tonight, it's been really nice to hear everybody's input on kind of why that is with the glutes and the hip flexors being so tight. So this has been a really awesome to listen and talk with all of you guys. And I also have some upper body measurements here, manual muscle test wise, because her family ultimately has goals for her to be able to help with transfers. So if you're just watching her movement, this is me asking her to lift up her legs one at a time. And she said it's easier on the left, harder on the right. Does anybody have any thoughts on the video before I move on to the next page?
So my only question is if you were stabilizing her, if you had your hands on her pelvis, maybe from behind, and asked her to do the same thing, and even help to facilitate and stabilize her in that weight shift, do you think she would have more hip flexion than she was able to show you? Because what this activity was asking her to do was to weight shift, to stabilize on the right in order to lift the left, and vice versa, which is a lot of muscle groups involved in that. I'm just curious to know if you stabilized her and helped her shift, would she have more hip flexion than she was able to show you there? Do you think?
She does, but not by much.
Okay.
So we've done exercises like that in her wheelchair with me stabilizing with her feet steady. And we still have a lot of that kind of figuring out where she is in space, and then still limited range of motion through hip flexion.
Is she wearing any orthotics?
She has orthotics. She does not wear them. She has never came to therapy with them, and she only tells me she wears them twice a week. Range of motion wise, she is within normal limits to passive range at her ankles, in all planes. But she's never shown up to therapy with them.
Does she stand?
She
Or-
does at school.
Okay.
Yeah, we don't have a stander at our location, unfortunately. But yeah, she does stand at school.
Yeah, obviously that would be when she'd want to wear something to support her ankles.
Yeah, and I haven't really got into the meat and potatoes of how her school therapy is looking at this point. But yeah, and what they're working on and stuff. But yeah, I would hope she's wearing them there. Whoop. Okay. So PT goals, what's really important for her family is her mom is Madison is currently dependent in transfers besides slide board, which has been a really awesome goal that she met, is she was able to become independent with slide boards through therapy. But her mom is currently transferring not only Madison, who is a growing teenage girl, but her mom also is currently transferring Madison's dad also. So the want and desire to help improve Madison's ability to transfer is huge. Since the Chiari flare-up, she has been really limited in what we've been able to do strength-wise with her arms. So previously, our functional training in the room is we were having her transfer to the floor. I was giving probably minimal assistance on the down, maybe min to mod going up. Since that Chiari flare-up, we were really avoiding pushing activities, excessive Valsalva maneuver activities. So we lost a lot of strength. So this is actually the first time since the precautions were lifted that I asked her to move down to the floor. And I'll just kind of show you because, you know, as I share with you guys and hear all of your wisdom, I do have a lot of questions for you guys on how to help her improve her spatial awareness. So you'll notice she will adjust her arm position a lot of times as she's transferring. And I don't know what I can do to assist her in this transfer and feeling more confident. It's really like she's trying to figure out in space how she can get down.
Do you have a mirror in front of her?
I don't have a mirror in front of her at this time. I could try that. That'd be.
It would give her the visual input as to where her body is. So she got
Yeah.
down. Then what happens to her once she's down? Do you have like the next video?
I don't. I didn't want to take because it took I had to crop this video. It took probably about 2 minutes for her to find herself. This is the very cropped version. But she's able to get from her foot plate to her floor independently, and then from the floor to the foot plate, and then the foot plate to the wheelchair. That video took probably about 5 minutes of me letting her try to figure it out, giving her assistance with verbal directions, and then I ended up having to give that physical max assist to get back up. So I did not include that video because it took so long for us.
So it looks like she uses a lot of lats and a lot of triceps for that
Yes.
activity. So what is she doing? Does she go to a gym? Does she do anything to work those upper extremities and get those stabilizers strong?
You know, I don't believe she does any workout program. I've given her stuff to do at home, which includes a lot of closed chain weight bearing. We have done some like open chain tricep strengthening, but I think with her school schedule, I'm not trying to make excuses, but you know, with her school schedule, when she goes and does her gait training at school, she's relying heavily on her arms because she's always telling me her arms are sore the next day. So, you know, I don't think she has the current endurance to I don't know, she's just lacking that endurance. So, you know, I can encourage doing a program all I want, but we know as therapists, we don't always get compliance with the home program.
Right. No, I'm just thinking, you know, I mean, considering her age and everything, if she's not doing some kind of strength training, it's going to be really hard functionally to get what she needs. You know, even if you did something simple, like get some really long TheraBand and, you know, find the middle, tie the knot, put it in the top of the door frame and close it so that she's got this TheraBand hanging down where she could do lat work.
Right.
And then of course, you know, the sitting push-ups, if you have those, like, you know, the sitting push-up bars, you know, again, that gets the triceps and the lats, and that's probably a more functional, you know, that more transference to function activity, but just trying to think of some strengthening for the lats and the triceps, because that's really what she's needing, both
Yeah.
eccentrically and concentrically.
I'll look up the sitting push-up bars. I'm not super familiar with that, but Lisa T had a question about like I loved her question about like engaging the abdominals and seeing improvements, and you know, her family will really report that they are seeing, like, they notice, especially when she doesn't come to therapy for, you know, she had vacations or something, and then I was gone. She didn't come for a period of like 3 weeks, and they said it was crazy, the reliance that they started seeing on family for transfers and all of that stuff. So I love the conversations we're having here. It's great. Okay, movement on the horse. So we ride in a bareback pad. We actually moved to this slower horse for her because she was starting to have those Chiari flare-ups. And it wasn't, like I said, nothing occurred in session, but it was always afterwards she started getting these crazy migraines. So got her there, super heavy on the upper extremities. When we're on the horse, I am really trying to encourage her to get her hands off of the saddle. Sorry, this is fuzzy. It's gotten better, but with our fixed alignment at our pelvis, more weight through our left ischial tuberosity, we have a lot of difficulty, and the contractures, we have a lot of difficulty moving. We move as a whole segment. So I would love it if anybody had any insight into how to get her more successful with, you know, relying less on her upper extremities. And I've heard stirrups a lot today, so I don't know if stirrups might be beneficial for her.
So I know you're not going to love what I'm gonna say, and I'll be curious to see what other people say, and if Mary Helene is still on, because I can only see some of us. It really concerns me that she's mid-cervical spine to sacrum fused, because there's nowhere for that movement to go except to that cervical spine, to that, you know, above where she's fixed.
Is that why we see this kind of oscillating head here?
Yes. And it almost makes me wonder if that's why you were seeing the Chiari issues after being on the horse.
Sure.
So just, you know, it's just making me, you know, I want to say to you, just use incredible caution, because, you know, I mean, she has no control over any of the vertebral movement that's happening from the sacrum up until you hit where she's no longer stable.
Right.
So I would just, you know, I mean, it looks too like you are doing a lot of other things with her. And I don't know what would happen if you told this family, you know, being on the horse, you know, you would not do that. But I just want you to use extreme caution. Then, of course, the other concern is always, you know, heaven forbid anything should happen. And, you know, you guys are using a belt, so hopefully she would not land on the ground, but you would not want to be paralyzed, you know, putting her in
Right.
peril for, you know, impacting her spinal rods. So It's
Right.
frustrated me that path has changed, and taking it from a contraindication to a precaution. And I get it, everybody's different, but yeah.
Do you know why they did that change?
I don't, do you?
No, I'd love to, but I don't know.
Yeah,
I don't know if
no,
it's to make
I,
it more
maybe
accessible.
because there are people, like I had a girl I worked with who was in Pony Club with my daughters, and her horse stumbled and tripped over a cavaletti and literally did a somersault, and she ended up underneath the horse and became immediately paralyzed from the chest down. And when they went in and did the x-ray, her vertebrae were like several inches away from each other. And so they fused, I think 5 vertebrae total. That was how much they fused. She ended up getting complete return, neurologically. But her doctor would not allow her. We got in one visit because her pediatrician wrote the referral, but then the surgeon heard about it and he had a fit. So somebody who's got 5 vertebrae fused is much more likely going to do okay. What you always have to be aware of is that you're going to end up with hypermobility above and below the area of fixation. So with her,
Right.
there's nothing below because it's all the way fused to the sacrum, but she's going to end up potentially with, hypermobility above.
No, that's really good insight. A lot to take into account here.
I know, and it's not, I know it's not good news, but it's just.
Yeah, if I will jump in, Carol, because I am still on. And yeah, with someone who has this much fusion, I have to ask, always, what is the benefit here? She's not getting mobility throughout her spine, which is what we're looking for because she's been fused surgically. And
Right.
and just even the axial loading, that upward translation is going to be limited as well because of the fusion. So like Carol had said, you're getting the most mobility is coming out where she's not fused, which is right at the top of her head. So I would be thinking the same, is that, this is a perfect example. I hate to put it that way, but this is a perfect example of why, to me, regardless of what the precautions are, your clinical judgment has to come in where you know what the movement of the horse is doing, and is this really a beneficial, is this what you want to get to see happen? Is this excessive movement at the head what you want to see? And you're not really getting all of that rotation, anterior posterior tilt, lumbar flexion, because the pelvis is really limited because the fusion is right there to the pelvis even, so you're not getting a whole lot of mobility even there. So when someone has that large a spinal fusion, to me, that's a contraindication for me. I think that I can do more harm than good utilizing equine movement. So I either, if I don't have something else to accommodate them or help, like I think of Carol because she had a fabulous practice where she could utilize aquatic therapy as well. I don't have as part of my practice, but I like that's somebody I'd put in a pool. I don't know, Carol, what are your thoughts on that? But
Well, the problem with the pool is the bowel and bladder issue, and bladder's not such a big deal, but you really got to know what the bowel situation is, because otherwise,
True.
you know, you have
True.
potential issues there too.
Yeah, that's true. See, I didn't even go there, but see, this is why it's good to talk these things out. I just think that, yeah, I see more difficulty with it than benefits, or potential difficulty with it, where there's so many other great things that you're doing with her, not on a horse, that she clearly can benefit from. I don't know how invested, like Carol had said, her family is in this, but if they were really to be pushing it, and I could come up with a good reason that it was beneficial and some improvements, goals seen that you can correlate directly to equine movement, I would be sure getting an okay from the surgeon who did that surgery, that he's okay with that excessive mobility happening right above the level of the fusion. I have made those calls to find that out when I have a question, because I'd rather ask the question on the front end than wish I had asked it.
Right.
I would just say one other thing, and I do also have a little bit of concern about where your horse handler is. If there's a problem with this patient because the horse is having an issue, your horse handler is going to be the last person who knows about it and is going to be able to do anything to help you. So just that horse handler can't really see what's going on with the horse because she's right at his nose. If you can see the back of her right there in this frame. So that's just another thing to be thinking about in terms of providing therapy where we want horse handlers to be, so that they can actually control a situation with the horse if there's a situation that arises. I don't know how much control that you have on that, or
No,
input.
our wonderful leader is with Madison each week, and I think she was trying to get out of the frame with our dear Madison and our dear champion, who is one of the most lovely bomb-proof horses I've ever encountered, but he is slow as can be. And she usually does have extremely good positioning and is very aware. So,
Oh, well,
but I
that's
do appreciate the concerns with that. Yeah.
good.
Because I think we've
It's
all
just,
had handlers, volunteers who maybe there is something to be desired there. So thank you for looking out for that. Okay. I do appreciate all of the insight into that. And the family is, I've worked with her for 2 years, so I have a good relationship with the family, but I feel like with any family, when you're talking about the removal of, oh my gosh, what's the word? Removal of a service. I feel like there can be hard feelings with that. But I will take into consideration what you guys said and consult with the surgeon. Probably show this video because I think it captures a lot of the movement and kind of go from there.
So all that said, does anybody else have any input? Does anybody else have suggestions for Olivia? Should she decide to continue using equine movement to gain that control that she's wanting to gain?
I don't have anything specifically about using the movement of the horse, but I've been taking a course about the coaching model and family goals and things like that. And it sounded like earlier you said that the parents or the mom's real goal was helping transfers. So it seems like all of the lats and triceps kind of stuff you can get in there. And I don't know if there's some kind of groundwork you could do, like maybe have her transfer to something in order to brush the horse, or transfer, I don't know. I haven't gotten that far with it, but it just seems like trying to match more what you're doing to something that's going to align with the family's goals more, because she's not,
Right.
I know you're trying to get her arms up off the horse, but one of her family's goals is to get her arms more involved and stronger so they can help with the transfer. So maybe there's some creative groundwork. I don't know if she has like long leg braces or knee immobilizers that she could use to try to support herself in standing, and then brush. That seems like a you know, might be more than she can do, but I'm just thinking about those, you know, trying to keep the family's goals in mind, and maybe they would carry over more with their home program if you are more directly, you know, working towards and I know you are doing the transfers out of the chair to the floor, that kind of thing too, but maybe more upper extremity work might match up with their goals more.
I think that's a great idea, Lisa. When we talked about, you know, removing the horse, my brain was already trying to brainstorm ways that we can keep her at the facility, keep her, you know, still getting the mental health benefits, the social benefits of coming to Life Striders, and like get her doing some sort of groundwork. So, because then we would directly be addressing the upper extremities, and she would still get that horse interaction, that bond.
Yeah, that's really great idea. I know, Olivia, I mean, I've been in these exact shoes in that I worked with a girl. She was 13 at the time. She had cerebral palsy, and I'd been working with her since she was like 7. And when she was 13, she had to have exactly the same fusion that this young lady has had. And we had to have that talk that we were not going to be able to continue incorporating the equine movement once she had her surgery. I was fortunate in that I could put her in her own pool. And so we did a lot of aquatics. And then she did come out and do quite a bit of the type of things that Lisa was talking about. I mean, we weren't specifically working on lats and triceps so much, but we did do a lot of barn activities. And she loved, you know, she had a power chair, and she loved to lead the horse and, you know, just be involved at the barn. So we did figure out how to make it work and keep her happy and her parents happy.
Does your facility have a mechanical horse, such as an equicizer or anything like that?
Oh my gosh, it's called like the iGallop or something. I don't think it's made by Apple, but it's called the iGallop. I wouldn't feel very safe putting her on there with just how much upper extremity support she needs. But we do have that.
Just a thought. Our equicizer, we put one client on it, and you know, you don't have to move it, but just that upright position and just the fun of it, and also balance and postural control. I wonder if that would be something along with brushing, grooming, leading, feeding horses, things like that.
That's a really good idea. Thank you.
I've sat on an iGallop. I would definitely not use it for her.
Yeah. So what we have is the equicizer, and it's
Right.
much more stable.
We have an equicizer, and have a couple of patients who can't be on the horse for various reasons, but still like coming to our facility and the therapies that we can do, what we can do. And we do use the equicizer for them. I have yet to find anyone that I like the iGallop for.
No,
Yeah, I'm looking at pictures of the equicizer right now. That's not what I pictured, but that looks way more stable and safer than the iGallop.
Yeah, it's very stable. I mean, if you put her on a real horse, there's no reason why the equicizer wouldn't work. It's much easier.
the only downside to the equicizer is that it is very hard. And so I've found that using a mat, like the Airex thin mats that you lie on, I've put that over the equicizer just to soften it all up, because it is pretty firm.
You can put a
Does look
saddle on an
unforgiving.
equicizer or a bareback pad. It fits any standard tack.
Yeah, it does. It does.
Yes, I
Nice.
often sit behind my patients on it. And then I'm like, I need a pad for me. Like, I always like to have something for me as well.
Yeah. Yeah. So yeah, an equalizer is where you can still do tandem hippotherapy.
Yeah. Um, we have had overall patient successes, strength, posture, just being more confident, improved wheelchair propulsion, and then as I said earlier, just regressing if she's taken a big break from therapy. So I think you guys gave me some good ideas of how we can keep her strong, and I think this talk with the family is going to be hard, but I think it'd be a good idea to have.
Yeah, they're going to regret the fact that they okayed the pictures, but
I know.
I think if we just always want what's best for a patient, and it is hard to do that risk benefit analysis, but I think there's much benefit, as we've all discussed here, to being with the horses and around the horses and interacting with the horses. And it sounds like she's gained a lot from being in that environment, from interacting with these horses. And if she can continue to do that, just in a different manner, hopefully she will still be still be happy with coming out.
Right. And I don't know about you guys, but I find it sometimes difficult when one being newer to this field and just newer to PT in general and just learning, and two, it's hard when your administration is sending you, evals, referrals, and like maybe they're okay with certain things versus like actually talking with other therapists and being like, okay, this is contraindicated for XYZ. I don't know about your guys' facilities, who is sending you guys the evals and such, but I'm finding some difficulties with that because Madison is not the first person I've had where it's like, ooh, I don't know if that is appropriate for therapy, and there have been a few that I've turned away. Just for that reason.
You are absolutely right, Olivia. That is so hard. And it's especially hard when the doctors write the referrals. The doctors are writing the referrals and they know that they're going to be on the horse. And you're the one who has to be the bearer of the bad news that says, I'm sorry, but I really want your family member to stay safe. And here's the reasons why, I'm happy to provide PT services to this patient, and I'm happy to include the equine environment depending upon the ability, but being on the horse and the movement of the horse is more detrimental than it is helpful. And it's education, and it is going to be education on your part, Olivia. And I'm going to tell you, now that you and I are communicating via Messenger, if you ever have any questions, please always know I'm available to you. And I'm sure other people on here would say the same thing. If you have questions, reach out. Another place to reach out is the Facebook, the therapist, AHA therapist group page, and put your questions out on that and get people to respond so that, you can have that ammunition that you may need to, because if somebody's coming at you and they are your supervisor, they are, somebody who's over you, and you have to go back and explain why, then you need to have good rationale as to why, and be able to show them the reasoning behind it. But, you can educate them and maybe even help them to develop their policies and procedures so that it's written, with regards to, certain, just different patients or different scenarios.
Totally agree with you, and thank you for being a resource, all of you guys. That's why I was like, oh my gosh, I have to present in front of a bunch of people who have done this way longer than me. But that's why, being vulnerable and learning from you guys, and hopefully it's it'll be a better decision for Madison. And, you know, all the ideas you gave me for potential alternatives, I think will be great.
Yeah, and know that it doesn't matter how experienced we are. You know, we're always vulnerable when we present, but it's such a wonderful learning tool. And everybody has learned, I know, so much tonight. And, you know, with the video, because we're recording, other people will be learning from this as well. I mean, this has truly been a remarkable evening. You know, I know it hasn't gone exactly as you anticipated, but it has been, I know, a lot of food for thought for a lot of people. And you know, this is really what this is all about, is just us taking any scenario and saying, okay, well, you know, what would we do, and would we do anything different? And but, you know, just because we're experienced doesn't mean we know it all, and certainly doesn't mean that other people wouldn't see fault in what we would be demonstrating as well. So, you know, nobody here is perfect. It's just, you know, it's just we're all here because we are wanting to learn, and that's what it's really all about.
And Olivia, I have 2 comments. I think you did a wonderful job of putting together your presentation.
Absolutely. Yes.
And I think the one thing that we all have to remember is that it's our professional license that's on the line. And so, you know, we have to do what's best practice so that we don't end up having a problem. But also, this individual is a CLTS funding, which means that they have to have contact with the horse in order to get paid. It doesn't mean they have to ride. It just means they have to have contact. So, you know, I think that your ideas were wonderful on how to incorporate all those, like, more upper extremity stuff. And, you know, it got me thinking too. So I appreciate it.
Thanks, Joanne. That's
Yeah.
my coworker right there.
Oh, well, you're very lucky to have Joanne working with you.
Yeah, we in passing, we're so busy.
All right. Well, we have. Oh, go ahead.
Sorry, I have a question. Well, I have 3 things. I'm so sorry. One, I wanted to mention that the parent of my patient got back to me. Her spina bifida is at L1 and L2.
Okay. And that's exactly what we were saying based on what you told us. Yeah.
Well done. And then 2, I just wanted to mention, I love to listen to podcasts, and there are a couple of podcasts about spina bifida if anyone is interested. As far as quality, they're not the highest quality podcasts, but there is one that really does give you insight as to what it's like for adults with spina bifida. It's called Spina Bifida Talks, and her name is, hang on, Diamond in the Rough or something. Let's see. Diamond Crystal is her name, and she interviews people with spina bifida on each show. And you do learn a little along the way, just hearing about what they go through themselves and just the surgeries they've had and the different symptoms they all experience. You know, one person drives a car, one person works, one person doesn't, that kind of thing. And I just find it helpful to hear about these. Most of them are young adults, you know, what their lives are like, as I work with this child, the first patient I've had with spina bifida before. So just wanted to pass that along. And then third, I have a question, and I know it was discussed in the beginning about tethered cord. I understand the symptoms of tethered cord, you know, neurological signs, bowel and bladder difficulties, but I have a hard time wrapping my brain around that because, like you said, they already have difficulty with bowel and bladder. They already have difficulty with balance and walking. So, I mean, obviously I know the patient, and I've talked to the parents, and they, you know, will let me know if she's showing any of these signs, but just, do you have any additional tips or examples of some things that we might see besides, you know, just obviously, you know, obvious changes neurologically?
I don't know if anybody else here does. I do not. I have not worked with anybody with tethered cord. And again, like I said, I haven't had anybody on the horse that has had this diagnosis. So I'm at a loss, and I think it's all about change. It's all about what is different. But yeah, it is tough when you're saying you got to have neurological changes in an already neurologically impaired individual.
Right.
So,
This most
but-
recent scare they had was them saying her bladder, like it was just different for her. So that's how they knew. That's the only insight I have. It was just different from her normal.
Right, the
Thank you.
families are gonna know
Yeah.
what the normal bowel and bladder habits are.
yeah.
You know, there's a routine to the bowel movements, a routine to bladder emptying. And
Right.
it's the change from that, which will happen with growth. Another, just separate from spina bifida, even just in general, neuroscience, like sometimes toe walkers or later onset toe walking can be a sign of tethered cord. Not toilet training when we expect. Now, which again, some of our kids are not, our patients are not toilet training because of their disabilities. But some of the more typical kids who have more mild disabilities, and you expect them to toilet train at a certain time, and the kids who are really getting outside that norm, they'll often get evaluated
Interesting.
for tethered cord. I mean, one of my kids was late to train, and pediatrician immediately sent us for MRI to make sure that this was not a tethered cord issue. And one of my other kids is a toe walker. He also got an MRI to make sure.
And just curious, what happens when somebody is diagnosed with tethered cord? What does the process look like? Do they have surgery that day or?
So my kids did not have it. So I don't know from that. And I haven't actually treated anyone with it, but someone I know's kid was diagnosed recently. Actually, 2 of her kids were diagnosed. It wasn't immediate, but within a few months they had surgery. I think it'll depend on how severe those neurosigns are, and how severe the tethering. And sometimes these 2 kids, their scans were read as normal. The MRI was read as normal. And then they sent them to a specialist because the kids were symptomatic. So there were symptoms.
wow.
And they were sent to a specialist who read it and said, no, it is tethered. And then when he went inside, he said it was more severe than it looked on imaging.
And then once they have the surgery, is there potential for hippotherapy to be an appropriate tool of choice down the road once they recover, obviously? Or is
I
it
think when
like
things
never
are
again?
healed. No, I think when things are healed, they're healed. I mean, you have to talk to the neurosurgeon, obviously.
Yeah.
But
yeah,
it's not a bony surgery. It's a tissue surgery.
Yeah. Okay. Thank
So
you.
once it's healed, it's healed. These kids are having trouble. One kid is healing well and the other one is struggling. So.
Yeah, I just to add to that, and I think I put it in the chat, I have had instances where kiddos have had repairs of tethered cord, and then during years prior, so it's a precaution that we kind of were like, oh, so he had tethered cord, but it was repaired, okay. But then years later during a growth spurt, they found that it was tethered again. So it's something to just be mindful of what those symptoms are and keep sort of screening for that, especially if they're going through a growth spurt.
Thanks, Mary Helene. All right, guys, I think that this has definitely taken the record for the longest meeting that we have had, but this has just been, like we've gone down so many different roads in this discussion, and thank you all so much.
Thank you so much, everyone. I really appreciate it. Thank you, Carol.
Absolutely.
Thank you, everybody.
Does anybody
Can I ask
have
a quick
any
question?
Uh-huh.
Is this right here that you see? Is that the Facebook group that you're talking about? Is that the title of it?
I can't see. It should say American Hippotherapy Association Therapist Group page.
It says American Hippotherapy Association Inc. Therapist Group, and it says
Yes.
we need presenters.
Well, we've got that we need presenters ad everywhere. So that, it's probably on every one of AHA's Facebook pages.
Okay.
So we have a research page and we have a community page, but it would be the therapist group page.
Okay, so I can go ahead and follow that, and then I
Yes.
can make comments and ask questions on that.
Yes, absolutely. It's a wonderful resource. Does anybody
Thanks.
have a topic they would like to discuss next month? All right, so nobody's jumping at this. So not to put anybody on the spot, but be thinking about it, please. I'll put out a plea on Facebook. But if anybody has an idea, please let me know. Otherwise, what I may do is get in touch with Susan Facino, the woman in Mexico, who has just lots of kiddos in her practice. And so she's always able to bring up some interesting discussion topics with her different diagnoses. But if anybody else has anything else they want to talk about, just let me know.
Does it need to be a diagnosis or case studies, or can it just be a topic?
Like, give me an example.
Like research, like how to do research, or I don't know, I thought was a
Well,
random
this is a
example, but
case
just-
studies group.
It's
It's kind of
specifically
why
case
we
study, okay.
set this up. So, if you want to discuss research about a certain diagnosis, we can certainly do that. So, it's just we do need some direction as to how we're going to head with that. So yeah, just brainstorm. If you think of anything, let me know. We will plan to meet again. Oh, October 16th would be when we are doing it, and I have out of town guests, so I cannot do it October 16th. Mary Helene, is our
Hold on. Hello. Hi.
would our conference committee be meeting October 23rd or the 30th?
Honestly, I have no idea.
Okay. So we're going to have
I
to look
don't
into
know.
this. Yeah, we'll have to look into this and find out when we can even hold it. I just know I can't do it the 16th. So we'll just have to look at what else we have conflicts with on Mondays. So it may be the 23rd or it may be the 30th. I like to try to keep it on Mondays just because that's what everybody's grown accustomed to. All right. So everything TBD, but we will look forward to seeing everybody in a month or so.
Thank
you
you,
so
everybody
much.
who presented.
good
It was really
evening.
wonderful. And
Yep, it
thank
really
you,
was.
Carol, once again for facilitating and starting the ball rolling.
I
That's
love
great.
the videos.
Always my pleasure. Yes. And thank you guys so much for presenting your patients. And we really appreciate that.
Thank you.
All right.
Bye.
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 Bye.